Good evening. I'm Jonathan Kay from the University of Massachusetts Medical School, and I'm joined by my fellow RheumNow rheumatoid arthritis faculty members, Richard Conway from Dublin, Ireland, late in the evening, close to midnight, Sheila Reyes from the Philippines, 7 in the morning, bright and early, Jeff Sparks, who's also here in Massachusetts with me at 6 o'clock at night, just before dinner. And then we have David Liew, who's in Australia, in the Southern Hemisphere, who's already well into tomorrow. So we've all been through a long day taking anticoagulants, I hope, to prevent deep venous thrombosis from sitting all day. But we've had the first day of ACR Convergence, the first virtual meeting, and we've actually gotten to see each other a little bit. So it's not as isolated, but there's not that chance to walk through the hallways from meeting room to meeting room and bumping into people. So I'd like to open this up and see which presentations you found to be most interesting today. We've had a variety of presentations about rheumatoid arthritis therapy, cardiovascular disease, interstitial lung disease, potpourri of various topics related to the gut joint interface, some machine learning, and a plenary presentation about the infamous drug hydroxychloroquine that was touted by President Trump as the cure for COVID-19. Richard, what were some of the presentations that piqued your interest?
I'm going to go a little bit off piste. The most interesting presentation that I saw was actually a poster presentation. It was from a Spanish group led by Dr. Fernandez Diaz, and it was a rheumatoid arthritis interstitial lung disease poster. So I'm sure Jeff will have an opinion on it too. It was about using abatacept to treat patients with rheumatoid arthritis related interstitial lung disease, and very, very good outcomes. 80 to 90% of patients not worsening across a host of both symptomatic pulmonary function test and CT variables over the course of the study. I think that's very impressive data, given that we know that rheumatoid arthritis-related interstitial lung disease is a very nasty disease with a very poor prognosis and tends to be quite inexorably progressive once it starts. Now, they had 263 patients, so it was quite a large study, but it was observational, as has pretty much every study in interstitial lung disease and rheumatoid been to date. So I think those findings will definitely need confirmation in randomized controlled trials. But very exciting data, and gives us another option really to join rituximab and drugs that have some evidence for their use to treat interstitial lung disease.
Absolutely, very interesting. And Jeff gave two very interesting oral presentations about rheumatoid arthritis interstitial lung disease, the prevalence being a bit more than we've perhaps been used to in clinical practice over the years, and also very interesting association with cancer, which might have some impact on choice of therapy, abatacept or rituximab being potential treatments. Jeff, what are your thoughts?
Well, certainly, as you know, we've been very interested in trying to uncover this, what we call respiratory burden of RA. And honestly, it's not just people we know have interstitial lung disease. Certainly, a lot of people have subclinical lung disease. A lot of people have airways disease. We've shown that obstruction is more common in RA patients, independent of smoking. So there seems to be a spectrum of RA affecting the lung. And certainly, there's some patients that are severe enough that everyone would call it ILD. And those are the patients that obviously do really poorly. And right now, most of what we have is observational. There are some antifibrotic trials going on to understand how those could fit in for RA-ILD, but I completely concur with Richard that we need RCTs. This is not a fluke. It seems to be actually increasing in prevalence over calendar time. It seems to be one of the few important RA manifestations that's not getting better. So I think we should move forward with trials to really understand how to treat these patients, which are not rare.
David, what are your thoughts there?
Well, Jeff had a lot of good presentations today, but the final one of those I thought was one that really perked my attention. That was his group had looked at data from the UK Biobank cohort, and the presence of obstructive patterns of on spirometry, on pulmonary function tests, as well as restrictive, I think is really fascinating. We've seen these kind of patterns before. To see it validated in such a large cohort, and really, we're talking about a 28% increased risk for an obstructive pattern. This is it's becoming a real signal, and I don't think we really understand what is going on at that level. Clearly, it is, and it's something which has a meaningful impact on our patients. There is another one that I'd like to go even more off-piste than Richard, if I might, about there's an abstract actually after that from investigators from China looking at deep learning and X-rays. And it's always struck me that doing a SHARP or Sharp-Van-der-Heide score is incredibly painful. And in fact, what limits it in practice is the fact that it is so painful. We don't use it in clinical practice because it takes so long. And we worry that there's not that consistency between readers. So actually training a computer to do this, and they only used they only trained it off 1,400 X-rays. Imagine what it can do when you've got the greater potential. But this is the potential either to free up our radiologists from having to do a painful score, and I should say the machine performed exactly as well as radiologist scorers, or even more, could actually introduce it into routine clinical practice or bring it to the developing world. I think there's enormous potential in that, and that was actually quite an exciting abstract for me.
Absolutely. I thought that was a great abstract, and our radiologists don't give us sharp scores. It takes them too long. Radiology is a volume-driven practice, and to have a computer that could give us sharp scores that we could follow over time would be fantastic. So
yeah.
We're joined by Eric Dein from Johns Hopkins. Sheila, what was your favorite abstract today?
Okay, so like what David, there are a lot of good abstracts, but well, I chose one that what piqued my interest was related to the early diagnosis of RA, particularly one the early the subclinical synovitis and their non-progression to actual rheumatoid arthritis. It's an interesting abstract session. So where they looked into ACPA positive and ACPA negative patients and who would result or who had subclinical arthritis and who would eventually produce inflammatory arthritis. And their findings would show that not all ACPA positive patients with subclinical arthritis equates to the development of RA. So I think what the results would tell us is that, you know, it's really important that we incorporate our clinical assessments, our clinical judgments in our patients, and that the timing of giving this BMARDs would be very weighing the risk and benefits of giving this medicine. You've mentioned earlier about the leaky gut syndrome, so I found it also interesting in that it's a novel idea where the how the microbiota also plays an important role in probably the disease pathogenesis in RA. Um, the study mentioned about the microbiota being part of the pathogenesis. And when asked about what certain pathogens would have been causing this problems, well, the study did not include that yet. So I'm excited to hear about the results. There.
So that's very interesting. It actually ties together a couple of different themes because rheumatoid arthritis, preclinical rheumatoid arthritis, may begin in the lung with citrullination of proteins in the lung and the development of anti-citrulinated antibodies. Jeff identified anti-citrulinated filigrin as being an important autoantibody. So rheumatoid arthritis may begin with citrullination of lung proteins and the development of autoantibodies to those citrulinated proteins. And then the end result with interstitial lung disease in rheumatoid arthritis and established rheumatoid arthritis is also bringing us back to those autoantibodies. So there's a theme here. Eric, you just joined us recently. Welcome. What are your thoughts today? What's been interesting for you?
So I agree with Sheila that I thought that oral abstract session on the early RA studies was interesting, and I think the $1 million question is which are patients we can start to treat early? How do we prevent progression, stop RA in the track? So, I think the patient with arthralgias and positive antibodies we see frequently that we don't really know what to do with. And the study that Sheila mentioned was particularly patients that have subclinical synovitis. So, I'm curious to see what comes out as to, who are the patients that we should be getting ultrasounds on or MRIs on, and is it maybe not every patient will progress, but a lot of them still do, and can we actually change the natural history if we start the methotrexate or DMARD early?
Absolutely. It's amazing how rheumatology has progressed. I'm not that old, but when I was a first-year fellow patient, we were told by our fellowship director, Ron Anderson, that patients with rheumatoid arthritis got to know their orthopedic surgeon much better than their rheumatologist, because all we could do was give them hydroxychloroquine or gold shots or occasionally sulfasalazine, but they would never get better. And then we started using methotrexate at very low doses. But now we're talking about prevention, which is wonderful. We have imaging techniques that we can use to see subclinical disease, and there are home scoring systems. Vivian Bykert gave a presentation where she administered a homunculus, or she and her colleagues administered homunculi to patients and compared their assessment of the joint exam to those of physicians, and found quite good correlation, except at the highest levels of disease activity. So a patient-derived HAC or DAS or CDI, or those could be used for telemedicine purposes. So we've come a long way, and we're making tremendous progress. This is wonderful.
Yeah, I think that was an early highlight, because I think we're all forced to do telemedicine more than we ever did. And, I think we're all using Rapid 3 and other measures that, we don't feel are necessarily optimal. And if a better tool that could be used remotely is found, I think that was a real highlight of the meeting so far, particularly in this era where we're seeing people over video at best.
Right, and unfortunately in Massachusetts today, there was just announced over 2,000 new cases of COVID-19, the highest number that's been detected in quite some time. So we're seeing another surge, and we may be going more to telemedicine. For us as rheumatologists, where we rely on our tactile sense for the joint exam, we really have to investigate these other modalities, using thermography, which when it was presented initially a couple of years ago was thought to be sort of superfluous, because why would you need thermography? But now, perhaps a patient can go to Home Depot, buy one of these temperature sensor guns, and tell you what the temperature of their joint is, and that might give you a little bit more information for your telehealth visit. So,
from experience with that, though, I have to say I tried to buy a thermography machine here in Australia for kicks a year or two ago, and there's real variation in them. And I think I guess that's the thing with all of these things, that there's enormous potential there, but to be able to bring that price down to something which is going to be achievable in market for the really good quality things that deliver you the product, I think it's one of the real challenges in this time. But if there's anything that can do it, anything that can drive that kind of change, it's going to be COVID.
Absolutely. And the ACR convergence meeting has focused a lot on COVID. There were presentations today about the effect of disease-modifying antirheumatic drugs on outcome in COVID, and certainly the study of dexamethasone, which showed decreased mortality in patients requiring mechanical ventilation or oxygen with dexamethasone, demonstrates the importance of anti-rheumatic drug therapy or anti-inflammatory therapy. And certainly, I'm sure we'll see more and more investigation of our drugs. There's a late breaker about tocilizumab in COVID coming up, and the ACR has adapted to this new world very effectively at this meeting. So, well, we've had a wonderful discussion that's just given a very brief overview of a number of the presentations that have piqued our interest. There are more discussions, individual discussions, more in depth about specific presentations that you can access on Room Now, and we'll come back tomorrow evening again with a wrap up of the highlights, and then there's going to be Room Now live tomorrow night. So look on the Room Now website and join us again for more Room Now at ACR Convergence. From Ireland, the Philippines, Australia, Boston, and Baltimore. Good night, and we'll see you tomorrow.
And good morning.
And good morning.
Afternoon. Bye.